So I think like determining etiology is not really the correct way to put it, because we know from stroke AF, for example, that the AF rates in cardiovascular risk patients, they are exactly the same, whether the stroke is an like cryptogenic stroke, like in crystal AF, or if it was a symptomatic carotid or small vessel disease, such as in stroke AF. If you look at the curves, the AF rates and probably the burden as well, because they use the same definition, is the same. So I think we need to move beyond this. We neurologists are the detectives. We want to clarify the etiology. I think we need to move beyond etiology, and AF detection after ischemic stroke should be also done in patients with a small vessel disease stroke or a large artery disease stroke. It should not be used to clarify the etiology, but it should be used to prevent the next one. And the next stroke might be AF related also in a patient with a lacunar ischemic stroke, or it might be AF related in a patient with a symptomatic carotid stenosis. The important thing is that the shared risk factors, they increase the rate of AF also in those patients. And I mean, the data is certainly more sound on the predictors of AF in the cryptogenic stroke population. So we know dilated left atrium, NT-proBNP, supraventricular extrasystole, etc. So we know all the predictors. There has been also predictors confirmed in the other etiologies. They look very similar. So dilated left atrium, for example. And I think the prolonged monitoring should be used in those patients where we assume that AF will be picked up, but with a short monitoring duration of up to 30 days, as stated in the American guidelines. I think we can exclude a relevant burden of AF already, and I think the invasive monitoring should be reserved for the ones where we have some indications that we will pick up eventually AF based on the biomarkers that we know are associated with AF.